Dear viewers, welcome to Critical Care Webinars from Young India Intensivist Forum. And this is the webinar we were supposed to do a couple of days ago, but unfortunately, because of technical glitches on Zoom, we were not able to do it. So Dr. Bagchi has been very kind to do this again for us. And a few months ago, he had done another one, which many of you had viewed, and it's up there on our channel, and many of you have viewed it. So today, again, this is another episode on hemodynamics, where he specializes. We are going to be talking about PAC waveforms and Guyton venous physiology. So Guyton venous physiology is somewhat of a niche topic because generally not covered in most of the webinars. So Dr. Bagchi is actually from India. Initially, education was in India, but now he's at Harvard. So he's assistant anesthetist in the Department of Anesthesia, Critical Care and Pain Medicine, Massachusetts General Hospital. He's assistant professor of anesthesia, Harvard Medical School. He's Director of Clinical Operations, Heart Center, ICU, Massachusetts General Hospital, and is the author of a very nice book in cardiovascular critical care. So with that, I hand it over to you, Dr. Bagchi, to take us through the next 45 minutes or so.
Thank you, Dr. Bansal. Can you see my PowerPoint screen or the presenters? Okay. Good. All right. Well, good morning, good evening, I guess, to most people in India. And thank you for having me on for a second time. I am going to, my disclosures are all related to my research support. None of that is relevant to this talk. So what I'm going to talk about today is very briefly, in the first lecture that I think I did in December of last year, I talked about venous pressures, CVPs, and right ventricular pressures. I'm just going to do a very brief recap because that leads very nicely into Guytonian physiology and how the Guytonian framework gives us a bit of a roadmap of how to think about hemodynamics. And I want to emphasize that it is not, the last word in thinking about hemodynamics. There are many, many conceptual tools that you can use, and I use, to think about hemodynamics. But Guyton's framework is a particularly nice one. And how does that help clinicians think about a sick patient, right? And then I'll talk about PA catheters in critical care. I'm not sure how common PA catheter use in India is. In the US and in Europe, PA catheters went through a period of decline because of all these papers that said there is no evidence for the use of PA catheters. And now we are seeing a bit of a resurgence. And I want to push back on this idea that there is no evidence for PA catheters, therefore we should not use them. So that's what I'll end the talk with. All right, so starting with a quick summary to tie into Guyton. The most important things about venous pressures are the simple ones, because venous pressures are small in magnitude, between 2 and 10, 12, sometimes a little bit higher. And so differences in leveling are hugely important. If your map is different by 5 points, whether it's 78 or 83, nobody really cares. But if your CVP is 8 versus 13, that can actually make a big difference in how you think about your patient. Never trust your monitor readings. Your ICU monitors are going to have a number on the screen. That number is oftentimes inaccurate, in part because some tracings will have increased resonance, or what some people call fling. The computer doesn't care or doesn't know about when to measure the venous waveform, so you want to be able to measure it at end expiration to get the accurate CVP tracing. And this is really important. This part, and this ties directly into Guyton's concept, is that the CVP is a composite of two pressures. It's one of the reasons the CVP is difficult to interpret, is that it's a complex metric. It's not just a number, it's a waveform. It describes what the heart is doing during a particular cardiac cycle. And the two pieces of information it contains, as I've shown on this little scribble here, is the first is what we think of as the CVP, or the filling pressure, right, which is the RV and diastolic pressure, which is the end of the A wave or near the C wave. And in normal people, that is sort of the same as the mean right atrial pressure. But the mean right atrial pressure, or the mean left atrial pressure when you're thinking about the left atrium and the wedge, is also what you can think of in what Guyton called the back pressure. This is the pressure against which venous return comes back to the heart, right? And when your pathology changes, so in this example here, you've got tricuspid regurgitation, the patient's still in sinus, so you have an A wave, then you have the tricuspid regurgitant CV waveform, and you have the sharp Y descent. Here, the RVDP, your filling pressure, or quote unquote, the CVP number, is still the end of the A wave. But the mean pressure in the right atrium is now much higher, right? So the pressure against which venous return is coming back to the heart is higher. The venous pressures in the systemic circulation are higher, the organs are more congested. And so it's really important to recognize these two facets of the CVP tracing. And in the Guytonian framework, we'll talk more about one way to think about these. And then the morphology of the CVP tracing provides really, really important information, which is completely missed if you just think of the CVP as a number. But again, I went over the CVP in a fair amount of detail the last time, so I'm not going to go over that. And the uses of the CVP, for me, primarily, it's the single most useful measure of RV function if you don't have a PA catheter. It's a really, really important guide to systemic congestion and the risk of acute kidney injury in most kind of shocks, with the exception of hypovolemic shock. I use it very frequently as a poor man's esophageal manometer to estimate transpulmonary pressures in ventilated patients. And yes, it can be used to guide fluid management. It is just not very good at it. And we'll come back to why in a second. It can be used to determine the adequacy of a fluid challenge. And it can be used to determine volume responsiveness if coupled with a measure of cardiac output. And this is where Guyton's work really helps us understand why this concept of the CVP number as being a metric of volume responsiveness is really flawed, and why the CVP is complex to begin with. And there's no doubt that, a CVP of 8 really doesn't tell you anything about whether this patient will respond to volume or not. But why it doesn't is not because the CVP is useless. It's because we are not asking the right question. And all the papers in the world, and there are literally, dozens, if not more than 50, that say we should stop using invasive pressures because they're useless, they're completely unhelpful, they don't improve outcomes. And I think these are all very, very misguided. All right, so that brings us to Guytonian physiology. So for a brief background, Arthur Guyton was a physiologist. I believe he wanted to be a surgeon in his when he was in med school, but then I think he might have developed polio, and that prevented him from going into surgical residency, and he became not just a physiologist, one of the preeminent cardiovascular physiologists of his time, and indeed of any time. When I was in med school in India, Guyton and Genong were our two primary physiology textbooks, and Guyton was, where I went for hemodynamics in particular. Of course, that was no longer written by Guyton. It was edited by other people by then. But I'm sure many of you can remember Guyton's textbook. So to understand what Guyton talks about, you have to be a little bit familiar with terms we don't use in clinical practice routinely. Some of them we do, and sometimes we misuse them, in my opinion. But these terms are the stressed and unstressed blood volumes, the mean systemic filling pressures, and the mean circulatory filling pressures, the Frank-Starling curve, which is the part that most people are familiar with, and I'll argue is somewhat misunderstood, the venous return curve, and then Guyton's innovation was that he superimposed the venous return curve and the Starling curve. People have studied venous return before Guyton, and obviously, the Frank-Starling curve goes back to Otto Frank and Starling. I think the paper came out in 1913 or something. But Guyton's huge conceptual innovation was to show that you could put them together, and that gives you better understanding of the heart system. And then it's really important because I'm going to talk about some of the criticisms of Guyton's work, and there's a lot of criticism in a certain corner of academic physiology. I want to emphasize that Guyton's model is a map. It's a conceptual description of the heart and the venous system. It is not supposed to be a minute-to-minute descriptor of hemodynamics. It's a way, I'm going to say this again later, but just as the map of a part of geography is not the same thing as the actual geography, Guyton's work is not supposed to explain every aspect of cardiac physiology. There are a number of things that he doesn't incorporate in this concept. That does not, at least in my opinion, make it less useful. All right, so stressed and unstressed blood volume. This is something that I think is generally taught in physiology, but then we sometimes don't pay as much attention to it. This is a nice illustration of what stress and unstressed blood volumes are. So as you all know, the veins are very thin-walled, collapsible structures. So Sheldon Magder, who's the first author of this, and you'll see a lot of Sheldon Magder references here because he's done some of the, I think, most prolific work in trying to explain Guytonian physiology for physicians, as opposed to pure physiologists and biophysicists. So imagine a thin rubber band or a balloon. When it's empty, it's like flat and collapsed. As you start filling it with air or water or whatever, it starts to fill. And for some time, there is actually no pressure or no significant pressure exerted against the walls because it is still filling. So the amount of blood that fills the veins without increasing the venous pressure is the unstressed volume. And then once there's more blood volume, once it actually starts to distend the walls of the veins, you create a stressed blood volume. An analogy, a simplistic analogy that Sheldon Magder uses is the concept of a bathtub, right? So in a bathtub, you have a tap that's filling the tub, and then you fill it with water. And you typically have a drain that, drains the water out. Now, suppose you fill the bathtub with water up to a certain point, and then you make a hole in the wall of the bathtub. Water that comes out of that hole only depends on how much water there is above the hole, not how much water there is below. So if you think of the venous system, the unstressed volume is all the blood that is below the level of this hole in the bathtub wall. And the stressed volume is whatever is above that. So to take a slightly more schematic approach, this whole beaker is your venous reservoir, and you create an opening somewhere in the upper third of the beaker, and you attach a tube there, right? All the fluid above the level of that tube is the stress volume. Everything below it is the unstressed volume, and the total volume is the total volume in the reservoir. So the pressure that drives venous return in this concept is the difference between the pressure in the stressed volume and the pressure at the right atrium, right? And the resistance against which this blood flow happens is the venous resistance. And it's important to remember that, if you have 4 liters of blood, or say 5 liters of blood in your body, about 70% of that is in the veins. This is something that is commonly taught, right? More than 70% of your blood is in the venous system. 10% or so is in the arterial system. The rest is in the pulmonary arterial system. And of that percent of blood in the venous, 70% of blood in the venous tank, about 3/5 to 4/5 is unstressed volume. Right. So if you're ever diuresing a patient with a CVP, say heart failure patient with a CVP monitor, or you're doing CVVH or CVHT or something, it is sometimes surprising to see that this patient is now negative by, 2.5 liters, and their CVP has gone from 17 to 15. Where did that 2.5 liters come from? Well, some of it has come from the unstressed volume. Some of it has come from interstitial reequilibration. But one of the reasons the CVP is not, there are all these papers that very accurately point out that the CVP is not proportional to total blood volume. And they're absolutely right. The point is, it's not supposed to be a measure of blood volume. It is a measure of the stressed volume in the venous system. And there's very little reason that a clinician actually cares about total blood volume, right? You care about perfusion, you care about congestion, you care about flows. You don't care about total blood volume, or at least I don't. So one of the ways you can calculate the stressed blood volume and unstressed blood volume experimentally is, like so many things in physiology, you graph it. You keep adding blood to the system. And as the compliance of the veins changes, so the y-axis is the pressure, the x-axis is volume, as the compliance of the veins change, it's initially curvilinear and then it becomes relatively linear, right? Because like many things, veins are relatively plastic in the sense that for a long time, you can fill them without increasing pressures, then the pressures start to rise pretty rapidly. And the assumption when you calculate stressed and unstressed blood volume is that you can take the x-intercept of the linear portion of the venous return, the sort of pressure volume curve, and the x-intercept is the difference. This is the stress volume. So in this case, the total blood volume is 5 liters, 1 liter is the stress volume, and 4 liters is unstressed, right? And it takes, to go back to that diuresis CVVH analogy I was using, it takes a lot of change in blood volume to change in this case, the mean circulatory filling pressure, but it also applies exactly the same way to the CVP to change the CVP a little bit. So you're adding or taking away like close to 500, 600 liters to get a little bit of a change in the mean circulatory filling pressure, or the CVP. And one of the reasons for this is that the stressed volume and unstressed volume are in constant communication with each other, right? And when so one of the ways the body responds to circulatory stress, whether it's hemorrhage, whether it's heart failure, sometimes sepsis, although sepsis is more complicated, is by transferring blood volume from the unstressed to the stressed compartment by venoconstriction. And that's shown in the schematic here, where, in this case, you have this represents the heart, the arterial system. This is the whole venous system lumped into one, and most of it is unstressed, and then this is stressed. And now you have circulatory stress, so there is more blood gets transferred. Think of it almost as an autotransfusion into the stressed compartment. Somewhat fine point is that this is a change in venous capacitance, which is the total ability to hold blood, not a change in elastance or compliance. Compliance, as you know, is the inverse of elastance. So if the blood shifts from the unstressed to the stressed compartment, your venous curve sort of moves to the left, but the slope of this curve, which is the elastance, strictly speaking, change in pressure by change in volume, that does not change as much. All right, so that's stressed and unstressed volumes. The mean circulatory filling pressures and the mean systemic filling pressures. So the mean circulatory filling pressure is simply the pressure that equilibrates across the entire vascular system when flow stops, right? So that includes the arteries, the veins, the pulmonary arteries, pulmonary veins, all of that. One of the things that you can see in an ICU, and this has actually been studied, but I also do this routinely in our ICU. Our ICUs, we have a lot of PA catheter use. Sometimes, unfortunately, patients pass away or we withdraw care, and you can actually see the pressures equilibrate. You can see the arterial pressure drop, the venous pressure rise, and everything sort of within about 2 to 3 minutes of the heart completely stopping, they'll hit, in my experience, between like 18 to 20, 22 millimeters of mercury, because these are sicker patients, they're not normal. The normal mean circulatory filling pressure is about 6 to 10 millimeters of mercury. The mean systemic filling pressure, again, as my and sort of somewhat academic discussion, is the pressure in the systemic veins, excluding, for the most part, the pulmonary circulation and arterial circulation, also at zero flow. And the difference in most studies, and most studies are animals and a couple of humans, the difference between the mean systemic filling pressure and the mean circulatory filling pressure is very small, typically 1 millimeter of mercury or less. So you will see some authors use these two terms interchangeably. Strictly speaking, they're not exactly the same. As I said, they're pretty close. In Guyton's framework, and this is a point of controversy, the mean systemic pressure, venous pressure, is the pressure that drives the venous return. So in other words, we are very familiar with the formula for systemic vascular resistance, which is following Ohm's law of the circulation. Pressure is flow times resistance. So arterial pressure is cardiac output times systemic vascular resistance. So the SVR is the pressure gradient divided by cardiac output. And the pressure gradient is assumed to be the mean arterial pressure minus the CVP. Now, in the Guytonian framework, this is an approximation, and it is not correct because there are multiple steps. The increasing the CVP, as you've seen in your clinical practice, if you've got somebody with heart failure and their CVP goes up, that actually does not change the systemic vascular resistance, the arterial resistance, right? So the pressure that's actually driving venous return in the Guytonian framework is the upstream pressure, is the mean systemic filling pressure. The CVP, or the right atrial pressure, is the downstream pressure. So this again goes back to the concept of the two components of the CVP, the filling pressure, the RV and diastolic pressure, and the mean right atrial pressure, or the back pressure. So the larger the difference between the mean systemic filling pressure and the right atrial pressure, the higher the venous flow. And of course, at steady state, the venous return has to be equal to the cardiac output. So in Guyton's framework, the venous return is co-equal to the heart in defining cardiac output. It's a little bit circular, but I'll come back to that in a second. And the mean systemic filling pressure is also downstream anatomically from the capillaries. So you have your aorta, then you have the large arteries, then you have the arterioles, and you have the capillaries. And then you have the mean systemic filling pressure. And the gradients are, like I said, the mean systemic filling pressure is between 6 and 10 millimeters of mercury in normal people. And typical CVP is about 2 to 3 millimeters of mercury. The gradient between the mean systemic filling pressure and the right atrial pressure is typically around 6 to 10 millimeters of mercury. Now, the gradient in the capillaries, to allow blood to continue to flow into the veins, has to be higher than the mean systemic filling pressure. And experimental data suggests about 10 millimeters higher. And the gradient across the capillaries themselves is about 10 millimeters from the arterial end to the venous end. So what does that mean? That means, say you've got somebody with a CVP of 2, we can assume that their mean systemic filling pressure is between 8 and 10, right, millimeters of mercury. Their capillary pressure is now add 10 to that, so it's 20 millimeters of mercury, and the arteriolar end of the capillary is about 30 millimeters of mercury. If your mean systemic filling pressure goes up, so think of heart failure, right? Your CVP is now 15, so that means your mean systemic filling pressure is 25, your venous capillary filling pressure is 35, and your arteriolar capillary filling pressure is around 45 millimeters of mercury. That's a lot of pressure in the capillaries. And if you go back and think about the other Starling's law, not this law of the heart, but the filtration dynamics across a capillary bed, right? The hydrostatic pressure now is much higher than it normally is. And the result of that typically is hydrostatic edema, tissue edema, pulmonary edema, whatever. So this is a nice, relatively recent paper in Critical Care in 2022, which gives a nice schematic of the circulatory system, right? And this is an extension of the bathtub analogy of Magda. So this is your venous reservoir, right? You can also think of it, in a bypass circuit. You've got this big bucket of a venous reservoir when you're putting patients on cardiopulmonary bypass. And you have this conduit that comes out somewhere on the reservoir. And the part above the conduit is your stress volume. The part below is unstressed volume and does not directly contribute to venous return. Now, and this sort of clamp across the conduit is the surrogate for venous resistance. That leads to the right ventricle. So this is your pump, the RV pump, pushing blood into the pulmonary circulation. Then that goes into the left ventricle. The left ventricle is a pump. It goes into the arteries, capillaries, veins, and back. And this is what fills the tub, right? The heart's work in Guyton's framework, the heart primarily is a pump that reduces right atrial pressure, allowing venous return to come back. And the right heart, and this is very, very true in 99% of patients, the right heart is your gate to volume responsiveness, right? In most cases, now if you have an RVAD, that's a different story, but in most cases, the left heart can only pump what the right heart gives it. So the right heart is what determines whether you're going to be volume responsive or not the left heart as much. And the other thing to remember is that the cardiac output in this analogy is the tap that's filling the bathtub. The tap does not directly control the venous return. The tap influences the venous return. Now, if I make a big hole here and blood starting to pour out, you've got a hole in your aorta and blood's pouring out, the tap's going to fill very little, and very quickly this bathtub will get depleted. But the tap does not drive the venous return. The tap fills the reservoir. Cardiac output basically fills the venous reservoir. All right, the Starling curve. So Starling curve, this was the experimental setup that Starling and his co-author Patterson used in 1914. Right? So this is a dog's heart. It's taken out of the body. You've got a pressure manometer in the IVC. You've got a venous reservoir here, and the venous reservoir is filling the right heart. You've got the aorta that's cannulated. You've got a left atrial pressure manometer, and you've got tubing. And then this is the Starling resistor. There's a little bit of a manometer there, and that's your sort of organs, capillaries, whatnot. And then this is your tap that's filling the venous reservoir again. And this was Starling's original set of curves, right? This is where you see the famous Starling descending limb in 2 out of, I think, 7 or 9 dogs. And this is what's been taken to interpret that the Starling curve has a descending limb. It generally does not. One reason is technical. The variable that Starling was changing in the experiment is actually the resistance of the Starling reservoir, right? He wasn't changing the right atrial pressure or the cardiac output directly. And so if you did it, if you graphed his data today, you would probably do something like this. This is the variable that you're changing, and then these are the dependent variables. The independent variables on the x-axis, the cardiac output and the venous return, the right atrial pressure, on the y-axis. That's a little complicated to interpret. More importantly, Guyton and others who repeated Starling's experiments in dogs and other animals have not shown the presence of a descending limb except when the animal is actively dying, right? And so what that means is, so this is your classic Starling curve. This is cardiac output or stroke volume, and this is your right atrial pressure. This is the ascending limb of the Starling curve, the steep portion of the Starling curve. This is the flat portion of the Starling curve. The fact that there's no descending limb means you cannot increase stroke volume by reducing the size of the ventricle, or reducing, in this case, more accurately, the filling pressure of the ventricle, by a purely sort of cardiac mechanical function. There are many other things you can do to increase that help when you decrease the size of the ventricle, but increasing stroke volume is not one of them. And the mechanistic reason for that, these two graphs are, this is a frog muscle. When I was in medical school, we used to still do, and I don't know in India if they still do this in medical school. In the US, they've stopped doing it. We used to have these smoke drums and the frog gastrocnemius muscle, and you gave it a little twitch and preload, offload. This is the kind of stuff that we would see, right? So you can see here, this is the passive stretch. So the more you preload the muscle, the more the passive tension changes. And as you give it the stimulus, it develops active tension, the dashed line here, and the solid line up here is the total tension. As you overstretch the skeletal muscle and it stops overlapping, the actin myosin filaments stop overlapping, it will reduce its contractility. That is absolutely true for skeletal muscle. Cardiac muscle is a little bit different for a couple of reasons. One is that in essentially any kind of heart, normal or pathological, because of pericardial constraints and because of the structure of the heart itself, it's essentially impossible to overstretch the heart to the point that it no longer has actin myosin overlap. The second is, if you think of this as a true descending limb, you stop to think about it for a minute, it becomes a very unstable situation. It's not a steady state solution, because say you were here and now you've suddenly, somebody gave your patient a volume bolus and now they've quote unquote fallen off the Starling curve. They're here. Now their stroke volume has dropped, but their filling pressure is still high, and the venous return takes a couple of heartbeats to equilibrate to the new reduced stroke volume. So what's the next filling pressure going to be? Even higher. That means your stroke volume gets even lower, and so it becomes a vicious cycle. So this happens when you're dying, and that's when you see a descending limb. In normal circumstances, there is no descending limb with the Starling curve. The venous return curve this is not Guyton's innovation. Other people have studied the venous return curve, but this is how he defines it, right? So again, he uses the same axes as the Starling curve. So on the y-axis, you have the cardiac output or the stroke volume, and on the x-axis, you have the right atrial pressure. And he starts from the point that when your right atrial pressure is equal to the mean systemic filling pressure, remember that we said that the gradient for venous return is from the mean systemic filling pressure to the right atrial pressure. When you take that gradient away, there is no flow. So at this point, this circle here, there is no cardiac output. As you keep reducing the right atrial pressure, flow continues to improve, and it becomes maximal when your right atrial pressure is 0. Now, is the right atrial pressure negative? Yes, normal right atrial pressure is often cyclically negative at least, but because you can't really drop, the veins start to collapse once the pressure in the veins is really low, you don't get an increase in flow based on the mean systemic filling pressure to venous right atrial pressure gradient, and so the flow becomes limited. And so for all practical purposes in this schematic, the lowest value of the right atrial pressure that affects cardiac output is 0. Now, and the slope of this line, so if slope is dy by dx, so it's change in flow by change in pressure. That is the inverse of the resistance, because the resistance is change in pressure by change in flow. So the slope of this line is 1 divided by the venous resistance. So what that means is if your venous resistance increases, the slope of this line decreases. If your venous resistance decreases, the slope of this line increases, right? And then if you give volume to your patient, you increase the mean systemic filling pressure, the whole curve shifts to the right. If your patient's bleeding out, the mean systemic filling pressure decreases and the slope of the curve shifts to the left. So now we can come to the combination of these two, and this is a figure from Guyton's paper in 1955, but his fundamental innovation was to show in a very simple graph that venous return and cardiac output are completely linked. You cannot really think of one without the other. Now, this has got a number of conditions. I'm going to simplify this. And one of his key insights it was that the intersection of the venous return, so this is the normal venous return curve here, and this is your normal Starling curve. The intersection of these 2 points is where the venous return is equal to the cardiac output, and that, for a given set of conditions, is your CVP. So in a normal heart with a normal venous return, this red dot shows you the CVP, which is pretty low, as it normally is. Now, if you've just given this patient a bunch of volume, and as you can see, they're on the steep portion of the Starling curve, you have increased the mean systemic filling pressure. You've not really changed the venous resistance. You've increased the mean systemic filling pressure, you've increased the CVP, and you've increased the cardiac output. Now, if you've got heart failure, you're now on a different Starling curve, on a lower right-shifted, flatter Starling curve. And if your venous return is normal, you see that your CVP is immediately gone up, right? And your cardiac output has gone down. So this tells you a couple of things. One, it tells you why the expectation that the CVP as a number, my patient has a CVP of 6, therefore they're going to be volume responsive. My patient has a CVP of 9, therefore they're not going to be volume responsive, is very, very overly simplistic. So all the studies that exist looking at this are asking the wrong question. You cannot think of the CVP when you're thinking of volume responsiveness. The CVP, again, as I mentioned, has a bunch of uses. But when you're thinking of volume responsiveness, you cannot think of the CVP as divorced from cardiac function. So, and that tells you why the CVP number by itself really does not tell you much about what the heart will do or the circulatory system will do in terms of volume. And it provides a roadmap, a framework to think of hemodynamics in critically ill patients. So this is a simple example of someone who's fluid responsive. So they are on, this is their Starling curve. This is the 0 point. That's why the Starling curve goes beyond this. And their normal venous return curve is here. You are giving them volume. You've pushed the mean systemic filling pressure up. The right atrial pressure changes, but not dramatically because you're on the steep portion of the Starling curve and your cardiac output goes up. If you are on the flat portion of the Starling curve, then it's somewhat the opposite. You've given them the same amount of volume. You've given them the mean systemic filling pressure changes by roughly the same amount, but because they're on the flat portion of the Starling curve, their CVP rises much more than the CVP does here, and their cardiac output does not change. So that is a fluid unresponsive patient. I routinely do passive leg raises in the ICU. Passive leg raises are popular even in the literature, even in people who don't like CVPs, because as you know, it's an auto transfusion. You're transferring blood from the lower extremities into the central circulation. But I do like to use the CVP in interpreting my passive leg raise responses. So volume responders can respond in one of two ways. In both cases, the cardiac output and or the mean arterial pressures will go up. But in very young, healthy patients, the CVP may not actually go up because the heart exists to make the CVP as low as possible. So you're giving more volume and the heart's moving it along. You're getting a better cardiac output, the CVP doesn't change. If your heart is slightly less robust or you're on a slightly steeper portion of the Starling curve, then your CVP may go up, but your cardiac output also goes up. If you're a volume non-responder, and this is again a good use of the CVP, is that your CVP goes up and your cardiac output does not. Right, so your CVP goes up, say your CVP was 8, now your CVP is 14 at the end of a 250 ml volume bolus, and your cardiac output or map are the same. This patient is definitely not a volume responder. When neither the CVP nor the cardiac output or map change, that generally means one of two things. You have not given enough volume to stress the circulation, and that's generally the most likely interpretation. You haven't changed the filling function of the heart enough to test whether or not the patient is volume responsive. A good example is somebody who's septic and very venodilated. The change may not, if the passive leg raise may not affect the stress volume as much. So I like to look at both the CVP and the cardiac output. If you look at most publications in this area, they're using cardiac output, the VTI by echo, pulse pressure variation, or some combination of that. They're looking at the left heart output. By looking at the CVP, you can combine that with the right heart filling function and the left heart output. And as I said before, the right heart is your gate to volume responsiveness. All right, I will skip this part because we've gone through these two cases before. Septic shock is interesting because it's much more complicated. So here what the authors are showing, and I actually disagree slightly with this. This is your normal heart. This they call a hyperdynamic state. It's really important to remember that the Starling curve does not give you contractility. It tells you nothing about contractility because it cannot. You need a pressure volume loop to think of contractility. This is just an increase in flow in response to low afterload. And we know quite well, actually, that sepsis is typically, even if the cardiac output goes up, the intrinsic contractility of the heart is reduced. So I'd be a little wary about septic patients in general. Their physiologies can be quite complex. So we'll go over the criticisms of the Guyton model. There are a number of authors who are, nobody actually critiques the experiment. This is a big difference between criticisms of Guyton and criticisms of Starling, the Starling curve. Starling's experiments have been difficult to replicate. There are a number of reasons for that. We won't go into that. Everyone who's repeated Guyton's experiments has found basically the same results. What they critique is his interpretation and not the mathematical interpretation. The math is all above board. Their problem is, one is the model's too simple, which is true. It is a very, very simplified model of a complex system. The big two critiques are, Guyton sort of used this to support his claim that the venous return, the mean systemic filling pressure to venous return gradient is the really important thing in circulatory physiology, whereas some of his critics will say, well, actually the heart is more important. And that's a reasonable academic debate to have. I would argue in clinical practice it has no meaning, because you should be interpreting CVPs and venous return in the context of cardiac function. And similarly, because some people they give more importance to cardiac function, the back pressures they pay less attention to. A lot the critiques come from electrical circuit analogs of the circulation. So there's a lot of super complicated and sophisticated math, and most of these authors are not clinicians. They're physiologists, they're biophysicians, they're not ICU clinicians, they're not heart failure cardiologists. So they miss, in my view, some of the forest for the trees. They're not wrong in their details necessarily, but it's less relevant for clinicians working the unit, right? So I think, and this is where I'll stop with Guyton's work, is that it's a conceptual framework for understanding the circulatory system. The map is not the terrain, right? So if you mistake one for the other, you're going to think the map is wrong. The interplay between the heart and the venous return is the most useful part of Guyton's framework. I've talked about cardiac output versus venous recoil, and a lot of these authors will talk about transfer of blood volume from the arterial circuit to the venous circuit to explain changes in CVP when the cardiac output goes down. That just clinically seems less likely, in part because the venous capacitance or compliance is between 30 and 100 times the arterial compliance. The arteries just don't have that much blood to fill the venous system to that extent. With that, we come to the pulmonary artery catheter. So this I'll be a little quicker, just focusing on waveform analysis. You all know that there's a ton of information we get from the pulmonary artery catheter. I think of them conceptually as direct and indirect, and this is not a full list. So the direct are the CVPs, the PA pressures, the wedge pressure, the mixed venous, thermodilution, cardiac outputs, temperature, right? Indirect is the kind of derived variables that we get from the direct variables, the transpulmonary gradient, which is the mean PA pressure minus the wedge pressure, the pulmonary vascular resistance, the systemic vascular resistance, the FIC cardiac index, the PAPI, the PA pulsatility index, the right ventricular stroke work index, a metric that I use and I like quite a bit, the cardiac power output, which is the MAP times cardiac output divided by 451. These are all indirect indices, right? The ones that I focus on are the CVP, I've talked about RV pressure monitoring in the last talk. The wedge pressure, I really, really think it's important to wedge patients, and I'll tell you why. The CVP to wedge ratio, for my money, is the single best. There's no such thing as a single best metric. But if I had to choose one metric to assess RV function, it would be the CVP to wedge ratio, because the normal CVP to wedge ratio is 1/3 or less. So your CVP is 2, your wedge is 6, 7, right? That's the normal relationship. If you've got a wedge of 18 and a CVP of 16, you've got a bad right heart. And one key thing to remember is that these are much more useful when the filling pressures are slightly higher. And you've got hemorrhagic shock, your CVP is 2, your wedge is 3. That doesn't mean you've got an RV problem. That means you've got a no blood problem. Right, the PAPI is the PA pulse, the PA pulsatility index. That's the PA pulse pressure by the CVP. The cardiac output and cardiac index are okay. There are many other ways you can get those. The PA catheter is not important, and the cardiac power output is useful. Again, the PA catheter is not essential to get a cardiac output. For me, the primary value of the PA catheter is to differentiate to phenotype cardiogenic shock, LV predominant versus RV predominant versus BIV, because the way you treat these kinds of shocks are actually very different, even though they're all cardiogenic shock. So why should you wedge or not wedge? The first thing, and this is really important for trainees, not necessarily for experienced physicians, don't wedge until you know what waveforms look like, and I'll show you why. The one group of patients I don't wedge, patients who have a PA catheter that I don't wedge, is patients who've had a pulmonary thromboendarterectomy, because you basically, the surgeons are cutting across the entire pulmonary artery to get the clot out, and then you don't want to stress those incisions. Again, don't rely on the monitor numbers, and pay attention to the tracing changes in the same patients, not just the trend in numbers, which is obviously important, but also what the tracings look like. So this, if I showed you this with no context, right, this may actually be difficult to interpret. If you're in a non-cardiovascular ICU that's using a PA catheter for some reason, this might be a wedge. This could be a patient on ECMO who's got very little PA pulsatility. So you don't necessarily know what this means, right? This is easier, but I've seen lots of people who don't realize that this is something has changed. This is the PA catheter has fallen into the right ventricle. So basically what you've got is a right ventricular pressure tracing, because the PA tip is now in the RV. So you need to advance the PA catheter. This is a wedge, but it's a patient who's somewhat vasodilated, and you've got it's not a pretty looking wedge. So the PA waveforms can be very, very variable. One of the problems with saying that PA catheters are not effective and not using them is that fewer and fewer physicians are able to interpret PA waveforms well. So if you looked at this tracing, and I just showed you this tracing, it wouldn't necessarily be an unreasonable thing to say that this is a normal PA waveform. But this is actually the wedge of the patient here. So you can see that the tracing here, the wedges, the V waves here are so high that they actually influence the PA arterial waveform. The dicrotic notch looks like it's got another peak. That's because the V wave, the left atrial pressure is reflecting back into the PA pressure. So if you think that, and this, if suppose you saw this waveform, and then you tried to wedge this patient, you would have a high risk of rupturing the PA because it's already in a wedge position, and now you're inflating the balloon. This is another useful tracing. This is a patient, if you think about it, is this a PA tracing or is it a wedge? Not entirely obvious. This is a wedge tracing, somewhat of an incomplete wedge. This is the PA pressure. So how do you know which is which? You time it according to the timing in the cardiac cycle. Remember that this is a high V wave, which comes during diastole. So it comes closer. If you see I've drawn white lines next to the ECG, the QRS complexes, this is much closer to the QRS complex, whereas the peak of the normal PA should be somewhat in the middle between two successive QRS complexes. Oops, let's see. Okay, so a couple of other random examples. What is this patient? You've got a CVP here, you've got a PA pressure, you've got two arterial pressures. The arterial pressure is completely non-pulsatile. The PA pressure is somewhat pulsatile with each ventricular beat, and you see that there's some pacing here. This is a patient on ECMO. You've got some contractility, which is reflected on the right side, which is reflected in the CVP, and a little bit of variation in the PA pressures, but the arterial pressure circulation is non-pulsatile. This is a patient with a relatively normal PA and CVP waveforms. The arterial waveform is non-pulsatile with these regular dips. This is a patient with a heart rate 3 LVAD, because the heart rate 3 is designed to create a pseudo-pulsatility sort of drop and flow every 2 seconds. This is interesting because this is where we sometimes make mistakes. You see, this is the CVP and this is the PA pressure. The CVP has no respiratory variation at all, whereas the PA pressure has more respiratory variation. What does that mean? They're both intrathoracic. This means that the PA catheter is probably in West Zone 1 or Zone 2, where it's responding more to changes in airway pressure with positive pressure ventilation in this case than it is to actual blood volume. So if you see this kind of a discordance between respiratory changes in the CVP and the PA pressure, you should be a little more careful about interpreting the PA pressures. And this is an example of something that's more common. This is a patient who's spontaneously breathing. I've changed the sweep speed so that it looks like the patient's tachycardic. It's not. You can see that the CVP tracing varies with respiration. The PA pressure, less so. There is a small variation, but it's not as pronounced as CVP. That's typically normal, and that means that the PA catheter is likely in Zone 3. You can't be 100% sure without imaging, but that would mean that the PA pressure readings are going to be more reliable. Advantage of the wedge. So this is an example here of, so why not use just the PA diastolic pressure? Why do you want a wedge? So in patients with pulmonary hypertension, there's almost always, if it's pulmonary arterial hypertension, I should say, there's a diastolic to wedge gradient. This is the PA diastolic pressure. You see, I've wedged this patient here and I'm letting them, I've deflated the balloon. This is the wedge pressure. And this is the PA diastolic pressure. The PA diastolic pressure is something like 20. The wedge pressure is closer to 13. You've got a 7 to 8 millimeter diastolic gradient. If you don't know that, your CVP to wedge ratio, your pulmonary vascular resistance, all of these calculations are going to be wrong. Right? So, and knowing the transpulmonary gradient and the pulmonary vascular resistance is essential if you're evaluating someone for a heart transplant, because if they've got a high PVR, typically more than 3.5 Wood units, you will not get them a new heart because that heart will die immediately when the RV is faced with these high pulmonary vascular resistances. So it's essential. There is no way around doing this in heart transplants. It is also nice to know when you're evaluating pulmonary hypertension and looking for responses to treatment, for example, with nitric oxide or intravenous prostaglandins or epoprostenol, sorry. And again, I've said that CVP to wedge ratio is my go-to metric for RV versus LV dysfunction. If there's a big diastolic gradient and you're using the PA diastolic pressures, you might underestimate RV dysfunction. So say your PA diastolic is 14 and your wedge is 13. You're like, okay, the RV is struggling, but not awful. But then if there's a 7 millimeter gradient and your actual wedge is 7 and your CVP is 14, this is a RV in serious trouble, right? So you need to be able to know what the wedge actually is. And then there's a whole bunch of reasons to look at the wedge in patients on mechanical circulatory support. In those patients, you don't necessarily need to wedge every time. Once you know the relationship between the wedge and the PA diastolic, you can use the PA diastolic to estimate the changes in wedge. All right, we are running out of time, so I'm not going to spend too much time on this. This is a recurrent question in patients with PA catheters. Do you do thermodilution cardiac indices or indirect FIC? My short answer is you should preferentially do thermodilutions. Why? Because the problem with the FIC, so your FIC cardiac output assumes that your mixed venous can be used to calculate cardiac output, provided your hemoglobin, your arterial oxygen saturation, and oxygen consumption are known. So the indirect FIC calculation allows you to take into account changes in hemoglobin and arterial saturation. The problem is your oxygen consumption is very difficult to calculate at the bedside. So we use nomograms. But But the nomograms are designed for awake patients at rest, not for patients who are ventilated, paralyzed, sedated, not for patients who are very cold, say coming out of a pump run, not for patients who are hypothermic. And in sepsis, you have no idea what the oxygen consumption is unless you measure it. So that's a big, so if your patient's intubated, sedated, if your patient is hypothermic, if the patient just had a seizure, in these conditions, the mixed venous, your VO2 estimate is going to be completely wrong. So I talked about this. And the classic reason for focusing on indirect FIC is the patient has moderate to severe TR. There's a decent amount of data now that shows that the thermodilution is actually more accurate than the indirect FIC in these conditions, in pulmonary hypertension patients with moderate to severe TR. The direct FIC, where you're measuring oxygen consumption, is the gold standard. But in 99% of cases, we don't measure direct FIC, we measure indirect FICs. The European Society of Cardiology, since 2022, has recommended using thermodilution over indirect FIC. The American societies haven't issued guidelines on that. Thermodilution cardiac output is also better correlated with outcomes than the FIC is. So in general, I prefer, even in patients with TR, I prefer the thermodilution. Now, if you think your thermodilution is really off, use something like an echo or some other way to look for a cardiac output. Is it closer to the thermodilution output or the FIC cardiac output? All right, and I'll close with what is the evidence? We're in 2026. Why should we use PA catheters? And the whole controversy is focused on, does PA catheter use improve outcome? And my argument is that a monitor is not supposed to improve outcomes. A monitor should measure what it is measuring accurately, number one. And number two, it should be safe. It has no responsibility to improve cardiac output. That is clinical outcomes. That is your responsibility as the physician. There is no evidence in randomized controlled trials. If you take apart the original Connors trial from 85, 86 or whatever in JAMA, which showed that PA catheter patients with PA catheters were more likely to die. Yes, because they were sicker patients. If you take those kind of retrospective studies out of the picture and just look at the number of RCTs that have been done, and there have been a bunch, none of them show evidence of real harm from a PA catheter. So I'd argue that the PA catheter doesn't hurt people if you use it correctly. If you ignore some of the waveform problems that I showed and you rupture their pulmonary artery, that is a user problem, not a PA problem. Oops. In patients without cardiac dysfunction, you're probably fine. It's the CVP. I'd argue the CVP is still useful, but the PA catheter is not necessary. But with cardiac dysfunction, and especially in cardiogenic shock, every single Western guidelines, cardiology society guidelines now recommend placing PA catheters. Based on what evidence? Based on studies like this. That these are retrospective studies, but what they show is that if you've got severe cardiogenic shock, the use of PA catheters to do complete hemodynamic phenotyping is associated with better survival. Why? Not because the PA catheter is magical. It's because when you use PA catheters in cardiogenic shock, they're generally being used at tertiary care centers where physicians are experienced with their use. And this is really important. They have the tools to deal with it. They have temporary MCS. They have VAD programs. They have transplant programs. The reason these patients survive is they get classified more accurately and their treatment can be escalated to the point where they survive. Not because the PA catheter does some magic. The PA catheter is a tool. It is up to you to use it well or to use it poorly. I will end by saying there's an ongoing trial that is run out of Tufts, which is a hospital in Boston, that is trying to randomize PA catheters in cardiogenic shock. It's called the PAC trial. I'm actually very interested to see if they'll even end up enrolling patients, because at MGH, for example, if you're in severe cardiogenic shock, we would be very reluctant to randomize you to a non-PA arm. There are places that would, but we wouldn't. So I will stop here. Thank you for your attention. And if you have any questions, I'm happy to take them. Now, if you've got heart failure, you're now on a different Starling curve, on a lower right-shifted, flatter.
Thanks, Dr. Bagchi, for explaining such a difficult concept, that is the Guytonian physiology, venous physiology, so nicely. It's really difficult to understand, I think, for a lot of people, especially the young ones, and some crazy graphs and curves. Thank you so much.
Yes. You're welcome.
Just give me a moment, 1 minute. Yeah. So, guys, if you have any questions, please put them up. Dr. Bagchi will be happy to answer them. So far there are no questions, Dr. Bagchi. I'll just make a few points and you can just.
Sure.
So I agree totally with you. When you said that Guyton's venous physiology is more of a concept rather than it being practical. Because if you look at it, the arterial side, we have all these MAP and resistance, systemic vascular resistance, and all these the parameters, and we use them routinely for hemodynamic monitoring. But what we have on the venous side, none of them have been incorporated into actual use. Venous pressure, mean systemic filling pressure, all these numbers.
Yeah.
So it's just a theoretical concept, right? What we actually use is the CVP, and Guyton did not have anything to do with the CVP. The CVP was discovered independently in 1950s, I think, by some anesthetists who were trying to see how much blood can be given, blood transfusion can be given after surgery, something like that was there. So Guyton never got into CVP. He has this concept which he explained, but we are not using this concept. There's no real use. So in fact, I did a paper on this and they appreciated it very much. It was published just 4 or 5 months ago. That is why I can say a little about this. And probably what we are doing now in terms of using the venous return and of the venous physiology is the VEXAS problem. Do you have any comments on that?
Yeah, a couple. So Guyton was very, very he didn't discover CVP. I mean, the CVP is a very old concept. He wasn't even the first person to examine venous return experimentally. But the piece that he brings into our understanding is the role of this CVP as a back pressure, right? The difference between the CVP and the mean systemic filling pressure. And so I use two graphical approaches to think about hemodynamics. And you're absolutely right about one thing. Guyton's papers, and I've read about 6 of them, essentially don't talk about arterial pressure, right? And this is one of those criticisms that he uses the arterial, he doesn't pay enough attention to the role of arterial pressure in creating a mean systemic filling pressure. And I think there is something very valid to that criticism. But the way I came to Guyton's framework is in understanding why people dislike the CVP measurement, because it tells you that the CVP should not be expected in and of itself to be a predictor of volume responsiveness. Most people, even today, and even certainly in the US, and I think my sense is that invasive pressures are more commonly used in India. I'm too far out of India now to know what the current practice is. But here, a lot of people just don't use CVPs. They don't look at the CVPs because it's useless. Guyton explains why that is wrong. That's a wrong way of thinking about the CVP. That for me is the single most useful thing that Guyton does. The second thing is that the other concept that I use a lot is pressure volume loops. Again, neither of these is a clinical tool, right? The pressure volume loops are very, very, very good in explaining things like why does afterload reduction improve survival in heart failure? Why doesn't inotropy improve survival? In fact, inotropy reduces survival. I won't go into that. VEXAS. I love VEXAS. I've been doing VEXAS now for years. And I would say that the two things are complementary. Where I find VEXAS most useful is so one of the things that I hope people will remember when they're thinking about CVP is that even if you take out all the complex physiology out of the CVP, a true high CVP is a really bad thing. If you've got a CVP of 18 and that's real, you don't need VEXAS because that patient is congested. There's plenty of data that the biggest risk factor for acute kidney injury, liver dysfunction in cardiogenic shock and septic shock is not cardiac output, it is the CVP. The higher the CVP, the higher your risk of organ dysfunction. And if your CVP is really high, you don't need VEXUS. If your CVP is 3, you don't need VEXUS. Where I use, and the part of VEXUS that I use the most, and I have now a personal library of about 100 plus VEXUS images. You mentioned the book that we wrote. I wrote the chapter on RV physiology, and I've given some examples of VEXUS there. Where I find VEXUS really useful is the indeterminate CVP. So your CVP is like 12 to 15. There, if I see your portal veins are really pulsatile, I will diurese. If your CVP is 12 and your portal veins are non-pulsatile, I won't necessarily diurese if there's not another indication for diuresis. So one of the things, I mean, obviously I'm talking about Guyton, I was talking about Guyton's physiology, so I was focused on that. But one of the things I tell my residents and fellows is don't use just one metric, right? Whether it's the PA catheter or the CVP or VEXUS or echo, put all of them together, right? No one monitor is going to give you the answer, the correct answer for every situation. The more pieces of information you can get into the puzzle, the more complete your picture of the patient's hemodynamics is. So I love VEXUS. I think VEXUS has a lot of value. Again, the data for VEXUS is actually most accurate to the extent I know from the work of the Canadians, Andre Deneau and the nephrologist. He's got a complicated hyphenated last name. I'm forgetting, it's Buell something. Is in patients with heart failure and cardiac surgery. General ICU patients, because they tend not to have bad hearts, tend to have less problems with congestion and VEXUS. Andromeda Shock 2, which came out a little while ago, was supposed to have a prospective VEXUS arm of Andromeda Shock 2. I still haven't seen that paper come out because in general, most patients in general ICUs don't seem to benefit as much from VEXUS because their physiology is not driven by a bad pump, if that makes sense.
Great, sir. Thank you so much for the answer. Then moving on to shock states. So in shock states and even in septic shock, there is venoconstriction and there is increased stress volume and the mean systemic filling pressure goes up, right? But venous, the resistance...
Maybe.
Yeah.
Maybe.
The resistance to the venous return also increases. So when the resistance increases, the venous return should kind of decrease, even though the PMSF is going up. So how do you, and this is, central to this concept. So is this...
Yes.
Or like, how do you explain this?
So this goes back to what I talked about of the difference between capacitance and compliance, right? So sepsis, and this is why I said sepsis is complicated. So what happens in sepsis? You can have typically classic sepsis, let's keep it simple. You have increased cytokines, you have arterial dilatation, you have venous dilatation, you have myocardial depression, right? Increased contractility with sepsis is generally not a thing. What you have is you will see a heart that's banging away on echo sometimes, and that is generally the result of increased systemic catecholamines, adrenaline, noradrenaline, whatever. When your venous capacitance increases, your mean systemic filling pressure typically drops, right? What changes in the venous return compliance doesn't typically change with venoconstriction initially, unless you're in a position where you're giving, 50 mics of levo or something like that, because what changes is venous capacitance. So let me pull up that graph and show you the graph. It is the change in so if you can see this, it is the change in the compliance curve, or the elastance, strictly speaking, the elastance curve. This is your venoconstricted patient on the right, right? The curve is shifted to the left. The slope of the curve has not changed. The slope, when does the slope of the curve change? The slope of the curve changes, of course, when you have obstructions, but it also changes at extremes of venoconstriction, and it changes with chronic venous, like you've got venous fibrosis, or you've got increased long-standing congestive heart failure with venous congestion and stress in the veins. So your venous media, the smooth muscle in the media hypertrophies. Those are the times where the venous resistance changes. This idea that because you're transferring volume from the unstressed to the stress compartment, that means your venous compliance or elastance is changing is not, in most non-extreme cases, not completely accurate. Right? It's a change in capacitance, not a change in compliance, if that makes sense.
Okay, sir. Thank you so much. Then something about the wedge pressure. A very fundamental question, sir. In cases of, let's say, mitral valve disease, high peak, or pulmonary venous hypertension, how do you actually allow for these confounding factors and estimate the wedge in terms of LV filling?
So the wedge pressure depends on, let me share the screen again and show you the examples. The wedge pressure, and this is why morphology is important, right? So you gave the example of mitral regurgitation, and this picture shows that really well, right? So this is the wedge in a patient with mitral regurg, right? Now, the wedge is here where the line is. The mean left atrial pressure is the mean area under the curve, which is much higher. So the LV end diastolic pressure is here on the sort of where it says here 20, right? But your mean left atrial pressure, the peak of the V wave goes up to 50 or 60. I think it's 50 because it says 52 here. So that's the mitral regurgitation component. That's why on echo with severe MR, you see reversal of flow in the pulmonary veins. That's what this is showing. So your risk of pulmonary edema is related to your mean left atrial pressure, not to your filling pressure. So you may have somebody, I don't know if you guys use impellers. I've had surgeons tell me, an impeller 5.5 can provide flows of 4.5, 5.5 liters. And then they get flash pulmonary edema from mitral regurg, and the surgeon's like, well, that can't happen. They're getting decompressed by the impeller. They don't get decompressed. It's complicated. LVADs do a much better job, like a HeartMate 3. But the reason you get pulmonary edema is high mean left atrial pressure, right? So you have to know which part of the venous, the wedge tracing implies what. The second nuance to remember about wedge pressures is that the height of the V wave is not necessarily related to the severity of MR, right? And this is something that I'm sure you're very familiar with. If you've got long-standing chronic severe MR, what happens to your left atrial volume? It becomes massive, right? The left atrium dilates. So in that case, the compliance of the left atrium is very high. So the V waves are actually much less prominent. On the other extreme, you have somebody with, say, a post-MI mitral valve caudal rupture, and you've got acute MR. The absolute increase in venous pressures isn't high because it's limited by a non-compliant left atrium. But now your mean venous pressure is super high, mean left atrial pressure, you're in pulmonary edema, and your V waves may not be that impressive. So the V wave is not necessarily correlated one-to-one with severity of MR, number one. And number two, you have to be able to, and this is critical in my practice because I work in the CCU with cardiologists and with heart failure patients that we are evaluating for transplant. You have to be able to get the wedge correctly to measure the pulmonary vascular resistance correctly, right? And that is the end diastolic pressure, not the mean left atrial pressure. So that is the reason to pay attention to the tracing. And the same thing is true for, pulmonary hypertension, the other picture I showed you with the diastolic gradient. There, the wedge is very, very normal wedge because by definition, pulmonary arterial, group 1 pulmonary arterial hypertension has a normal wedge. But the PA pressures are high, right? So with a high left atrial pressure, you will have high PA pressures too, but that's group 2. And that's because the left atrial pressure increases RV afterload in a way right atrial pressure does not do to the LV afterload, So it requires a fair amount of nuance to use PA catheters properly.
Great, sir. Thank you very much for the answer. Final point, sir. Right in the beginning, the first slide, you said you use the CVP as a poor man's esophageal manometer. So I understand that is because the esophageal manometer is generally for pleural pressure. The pleural pressure gets transmitted and increases the CVP. So how much of the pleural pressure affects the CVP? Is there a relation? I mean,
yes. So that's a great question. And so the manometer question, the manometer use application depends on a couple of things. One, it is the change in pressure, not the absolute pressures, because the change in pressure in the CVP is pretty well correlated with the change in pressure in esophageal pressures, right? Not so much the absolute pressures. So when you're breathing spontaneously and your CVP goes from, say, 10 millimeters of mercury to 0 millimeter of mercury, to make a very simple example, your delta CVP is now 10. And if you're on pressure support or pressure control, say, and you're on pressure control of 15 centimeters of water, 10 millimeters of mercury is approximately 13 to 14 centimeters of water, right? 1.36 to 1. And so your transpulmonary pressure is now close to 25 centimeters of water, which is potentially injurious. So that's the way I think of the poor man's esophageal manometer, the change in CVP. To your second question, there is no fixed ratio because the traditional teaching that, subtract half the PEEP from your CVP assumes equal compliance between the lung and chest wall because the CVP is within the chest wall but outside the lungs. The problem is all our sick patients have unequal compliances between the lung and chest walls. Why? So, for example, you think of someone with severe ARDS, right? Badly consolidated lungs. The lungs are very non-compliant. Very little of the PEEP is going to be transmitted to the CVP. We do recruitment maneuvers all the time. We've published on this in RV function. We can recruit you up to 45 centimeters of water and your CVP may go from, 8 to 12, right? And the 45 centimeters water is basically 35 centimeters of PEEP, 10 centimeters of pressure control. On the other extreme, you have someone with emphysema, hypercompliant lungs. There, especially if they're relatively hypovolemic, a PEEP of 7 centimeters of water can make you hypotensive from decreased venous return. So there's no fixed answer for everyone. And the other example is chest wall rigidity, right? So you have someone with, say, anasarca, abdominal compartment syndrome, and chest wall edema. Their chest wall is going to be the limiting factor, not so much their lungs. So the effect of the PEEP on the CVP depends on the relative compliance of the lung and chest wall. And it is in normal patients. So if, say, you're in the operating room doing, say a big case like a Whipple or something, but an otherwise healthy patient, you can use that 50-50% concept and make a rough guess of what the true CVP is. But in most ICU patients with pathologic lungs or other problems in thoracic compliance, that ratio is not consistent. And it's dangerous to rely on that. And the last thing to remember is that the congestive effects, so you have to think of the difference between transmural pressures and intravenous pressures. The congestive effects of the CVP don't depend on the transmural pressure. The flows depend on the transmural pressure. But if the pressure at your right atrium is 12 millimeters of mercury, your kidneys are roughly seeing that pressure, right? So a patient with a significantly high CVP, and this is where VEXs can be really useful, right? You look at, because mechanical ventilation and pleural pressure swings influence CVPs to some degree, you can use your VEXs as a sanity check. And if you see portal venous pulsations are my favorite VEXs component. Renal venous pulsations are more challenging. I get them maybe 60-70% of the times. Hepatic venous pulsations are more complex because they're normally pulsatile. So that in those cases, the VEXs can be a very, very useful addition.
Thank you, sir. Sir, I understand the complexities of the transmission of pressure, etc. to the pleural. But just if the pleural pressure goes up by a factor X, right? So does the CVP also go up by a factor X?
No, so I'll give you practical examples, right? So we've published this in the Journal of American Journal of Respiratory Critical Care Medicine, right? The Blue Journal. We've done with my colleague Lorenzo Berra, who's a world-class respiratory physiologist. We've looked at patients with ARDS and pigs, a pig model of ARDS. In patients with ARDS, we went from an average PEEP of 12 before recruitment to an average PEEP of 21 after recruitment. And during recruitment, we went to a maximum PEEP of 35 centimeters of water. The changes, so if the patient's CVP was starting out at, say, 10, and you increase your PEEP from 5 to 35, that's a 30 centimeter water difference, right? That's about, divide that by 13. So say a 20 millimeter mercury difference in PEEP. If 10 millimeters of that should apply to your CVP, you would expect your CVP to go from 5 to 15. In most of our patients, we saw it go up by like 3 to 4 millimeters of mercury. So because we do this literally every day at the bedside, we paralyze our patients, like patients with significant hypoxemic respiratory failure, obviously not others, but we do a best PEEP trial, and we define their optimal PEEP by compliance, sometimes by more complex things like esophageal manometry or electrical impedance tomography, but mostly by compliance. And when we do this PEEP titration, we look at the effects of PEEP, and this is something maybe we should publish, because if we take 20 patients and plot curves of CVP to PEEP, the changes in PEEP, right? You go from PEEP of 5 to 10 to 15 to 20 to 25 to 30, and you see what the CVP changes. You can tell in that given patient what the relationship between the lungs and the chest is. So it is not, if your PEEP goes up by X, your CVP will go up by X, right? It goes up by a proportion of X, and that proportion is variable from patient to patient and within the same patient as their clinical status changes. As the ARDS gets better, or say they have cardiogenic pulmonary edema, which gets better obviously more quickly than ARDS. They're in florid pulmonary edema, they're transmitting very little of their PEEP into the CVP. As the pulmonary edema is getting better, their lungs are getting more compliant, they're transmitting more of their PEEP to the CVP. So it's not consistent.
Yeah, great. Thank you, sir. Thank you very much. It was very nice, and I really learned a lot. I enjoyed it, and I'm sure the audience, the vast audience, they enjoyed it, and we put it up on the channel. Thank you very much, Bagchi sir, for all your time. Wonderful. Maybe we'll see you again, sir, with another topic. Thank you so much.
Not at all. Thank you, Dr. Bansal. It's been a pleasure.
Great, sir. Good night to the audience. Take care.